Thank you. This was really interesting, and I wonder if magnetic stimulation of the phrenic nerve could help to prevent in the patient that to have to sedate very deeply.
This is a very interesting suggestion. There is only one animal study conducted in Belgium by Ghislaine Ramirez and Mark de Kramer's group, showing that if you allow the animal intermittently, once per hour, to take a few breaths, you can really provide some protection. And we have in paralyzed patients after accidents, we have electrical stimulation of the phrenic nerve, which gradually over a period of time increases diaphragmatic thickness. So there is no direct proof that that approach works. It makes sense that it might work, but we don't know how often we should do it and how much we should recruit the diaphragm to prevent the injurious process. So this is the only thing we know.
Okay, I have one question. When you have a patient under pressure support after prolonged mechanical ventilation, and you are able to strongly reduce the level of pressure support between day 1 and day 3, and do you think it's a recovery from the muscles, for example, from VIDD, or its sedation is eliminated in 3 days? Is it not too short to say that the muscle has recovery from a prolonged, because that's what we see in real practice. We can decrease the level of pressure support within the first 3 days of the weanings, and the patient is still well with the respiratory rate and the tidal volume?
Well, this is a rather difficult question to answer for one reason. First of all, in the majority of patients, you might prefer to do pre-support weaning, okay? But you don't have to. It's not obligatory. You can stop sedation, put the patient on the T-tube, and 80% of the patients can do well. So only with that thinking, this is not that the majority of patients will have this problem. And in fact, it probably depends on the level of contractile capability that the patient enters the ICU. We have a 30 to 40% reduction in the contractile output of the diaphragm, but if the diaphragm was previously healthy and the load of the respiratory system is not huge, then even the reduced contractility, the patient can cope with the load. But if the patient was weak from the beginning, or relatively weak, and the load is high, then the additional reduction in contractility caused by controlled mechanical ventilation could be a problem. To my understanding, as a clinician, most of the effects I'm seeing in patients is due to sedation. So the main reason, at least in my ICU, which is not the best ICU in the world, but probably is not the worst, of vasoactive drug use is not septic shock, is more sedation than needed. I mean, I cannot really tell you how much sedation you have to remove. And it depends on what sedation you're using and what patient. In an old patient that you have used not only propofol, but you have used benzodiazepines for long, that have a depot, yes, sedation could be a problem, prolonged sedation. And there, NAVA could be a very useful tool, to see the EDI, how it behaves. Because we have no real evidence that the EDI, the EMG of the diaphragm, changes at all after controlled mechanical ventilation. The EDI decreases in amplitude, doesn't change in any other aspect. So if it's present.
Thank you. Any other questions?
Leo.
I'm interested in your second point. Do you really use antioxidants in patients who are on controlled mechanical ventilation for prolonged periods?
I have tried to do it in some patients, and I'm thinking, people like to think big, even if they are not. So I'm trying to think of a trial to really use antioxidants and prove the concept. But this has to be a multicentric trial, and the most difficult thing is what is the primary outcome that you are going to measure. We have registered in around 20 patients, that if you determine the thickness of the diaphragm at a specific position with different levels of PEEP every day consecutively, the thickness is reduced. So probably this could be an easily applicable measurement if we prove that it is really related to contractility of the diaphragm. But unless we develop that relationship and we're sure, I cannot really find any direct measurement that could be used as an outcome in a clinical trial.